Hello, everyone. Thanks for joining us today. This is Martha King. After a brief introduction for the webinar, you'll hear from several NCSL staff about some of the health issues that are gaining attention so far this year. I and our NCSL team of health specialists are here to serve you and your information needs. Please contact us anytime. And we welcome your questions or comments at the end of our webinar. To communicate, please type your question into the Q&A box on your screen. Health topics gain a lot of attention in state legislatures. After all, about 30% of the average state budget is allocated to health services. The bulk of this funding goes to Medicaid, as you probably well know. Medicaid is the primary program that covers low-income Americans. In addition, states play important roles in regulating health markets, protecting the public's health, and paying attention to populations that have particular health challenges, which may cause disparities in health. And as you well know, state legislatures deal with dozens of health issues from A to Z, with many issues in between. Although NCSL desires to assist you with all of your health information needs, we can't cover everything in one short webinar. So today we've chosen a few selected areas out of the hot health topics that many states are tackling this session. Among these are reforms in Medicaid, a look at health exchanges and insurance trends, and even breaking news from this morning, as Dick Carty will tell you about enrolling in health exchanges, how telehealth is helping extend the reach of providers, what the measles outbreak means for state vaccination policies, and some other public health issues, what new blockbuster drugs may mean for patients and states, and we have the never-ending pursuit to control health costs. And we'll hear about a couple of emerging hot topics, such as marijuana policy and e-cigarette regulation. I'll now turn this over to Melissa Hansen to talk about what's new in Medicaid.
Great, thank you, Martha. As Martha mentioned, the Medicaid program comprises a significant portion of state budgets, accounting for about 18% of state general fund dollars, or 23% when you include the federal match. In an effort to increase the program's return on investments, states are experimenting with many types of reform, some in coordination with the Affordable Care Act or the ACA, and some that are completely state-based. When states address waste and create policies that improve the value of Medicaid, they are getting better care for each dollar invested. In the coming year, we anticipate seeing lots of innovations in the following areas. States are changing the way they pay for care to emphasize prevention and to reduce unnecessary treatments or hospitalizations. Not by rationing care, but by incentivizing providers to help manage their patients' health and chronic conditions. In a handful of states, these efforts are being supported through the ACA State Innovation Models Initiative, or SIMS. The SIMS innovation is providing financial and technical support to states for the development and testing of state-led, multi-payer healthcare payment and service delivery models. The goals of these models are to improve health system performance, increase quality of care, and decrease costs for Medicare, Medicaid, and the Children's Health Insurance Program, also known as CHIP. SIM states are required to evaluate their reforms for both quality and cost containment. In round one of the SIMS initiative, nearly $300 million was awarded to 25 states. In round two, over $600 million was given to 32 awardees. There are two types of awards: model design for states that are creating plans and strategies, and model test for states that are implementing existing plans. States are also using data to identify and to map high utilizers. That is, patients who are using more health services than they might need, or are getting lots of services with no corresponding improvement in health. States are mapping clusters of these types of patients by neighborhoods in places like New Jersey and Maine to see if more intense case management can improve their health and contain costs. States like New York are using data to root out fraud and abuse in the system, and yet still other states are using data to reduce prescription drug abuse by proactively alerting doctors to possible trouble. As more and more payment systems become real-time data-driven, the need for trustworthy sources and analysis of data increases. legislators may want to think about their state's capacity because in a recent survey of Medicaid directors, one of the barriers to implementing value-added reforms identified was a lack of staff capacity around data and analytics. Medicaid programs, on average, are lean machines in terms of administrative cost. States do not want to lose that, but also want to build the expertise needed to improve the entire program. Finally, as states reform their health systems while simultaneously experiencing demographic shifts, the requirements put on providers change. Many of these reforms require changes in the practice habits and business models of provider networks. Legislators are looking for innovative ways to meet these challenges while supporting providers in their states. You will hear about one of these, telehealth, in more detail later in this presentation. But states are also using recruitment, retention, scope of practice, GME, or how medical education is paid for. And contrary to what often gets media coverage, increasing the quality of care and the cost effectiveness of Medicaid is not solely a partisan issue. Over the last few years, Medicaid has consistently been a hot topic because the program can be improved. And while there is plenty of good-spirited debate on how to improve it, the general consensus is that it can be improved. And to do this, state policymakers are looking at what drives both cost and quality. To move the dial on quality and cost in Medicaid, it is important to keep in mind the multiple roles Medicaid plays in the health system and to think about how reforms will impact all of the Medicaid stakeholders in your states. Medicaid serves as a coverage program for multiple and unique populations. It serves as a major payer to providers and can be used to influence the healthcare marketplace. Medicaid finances the majority of long-term care in this country. And the program is a joint federal-state partnership, meaning that states must work with the federal government within federal government guidelines when implementing changes. State legislatures are addressing Medicaid through legislation, but state agencies are also addressing Medicaid's return on investment. This slide shows which reforms are top priorities for Medicaid agencies. Important to know for state legislators hoping to engage their agency in dialogue about value. It is worth noting that 75% of Medicaid agencies are engaged in 4 or more reform initiatives simultaneously. ACA implementation is a top priority in many states, including the ACA-related Medicaid expansion. Not all states are expanding Medicaid at all, as you can see from this map. And of those expanding, not all states are expanding Medicaid in a traditional manner, but are tailoring their expansion to fit their state, including using Medicaid dollars to purchase insurance products available on the market for the newly eligible individuals. This is referred to as premium assistance. States are also engaging beneficiaries in new ways, trying to increase personal responsibilities of those beneficiaries. So as you think about Medicaid reform over the next year, it's important to keep your eye on a few moving targets. CHIP funding will expire in September 2015 unless Congress reauthorizes the program. Any changes to the ACA, whether that be through the court or through Congress, will have impact on how states can reform their Medicaid program. Workforce readiness, which I mentioned earlier, is an issue that states will have to keep their eye on. It's no longer a question of just provider shortages and maldistribution, but are your providers being trained to work on teams, use technology, and in a cultural competent way? As Medicaid undergoes major changes over the next few years, it is inevitable new challenges and opportunities will arise. I encourage legislators interested in Medicaid to reach out to NCSL often with questions or to get updates about the latest state reforms. Quickly, before I turn it on to my colleagues, I would like to alert participants that you can download the PDF. If you go to the top right of your screen, you will see a blue chart-looking icon. If you click on that icon, you can download the presentation. It is to the right of the microphone. With that, I will turn the presentation over to my colleague, Dick Kulke, who will talk about insurance and private market options.
Thank you, Melissa. My work covers several areas, but today I'm going to concentrate on current hot issues on health insurance, and in particular, key developments with health exchanges or marketplaces. More than 175 million Americans rely on the private or commercial health market for insurance. That said, this 6-month period has a true blizzard of activities. The exchanges or marketplaces established by the 2010 federal health reform are operating in all 50 states, and they've grabbed the headlines this week. This past Sunday was the deadline for uninsured to sign up, but in almost all states, it's been extended to February 22nd. Just this morning, HHS announced a further extension and created a 45-day extension that they describe as for those who were unaware or didn't understand the implications of the fee for not enrolling in coverage. CMS will provide consumers with an opportunity to purchase health insurance coverage from March 15th through April 30th. So that is somewhat unexpected and is certainly a significant change in terms of eligibility or flexibility. HHS has also announced that more than 11.4 million people are now enrolled, with about 85% of those receiving health premium subsidies. For state specifics, NCSL has been a leading source tracking activity and results. So visit our website or contact us for information about your own state or your neighboring state. On March 4th, 12 days from now, the U.S. Supreme Court will hear oral arguments on whether premium subsidies can in fact continue to be available in the federally run exchange states. An estimated 6 to 8 million policies could be affected by the decision. Third aspect is that states actually have the power and the option to select which marketplace structure they use, a federal, a state, or a variation. This map illustrates the structures that are in place now, and it shows that there is some definite diversity and even creativity by states. Here's the breakdown. There's 16 states, basically in green on here, that are certified as state-run, and the rest are really considered federally run in blue. Of those, 7 are actually state and federal partnerships. As I say, states can apply to change from a federal exchange or from a state back to federal. In 2014, 14 states considered bills to make that kind of change, although essentially no changes were made. In 2015, 9 or 10 states will debate proposals to make those kind of changes. But with the court ruling expected in late June, when many states are already out of session, the legislative choices may not be easy. And for this issue, don't forget the option of legislative oversight. No matter what your structure, the legislature can play a role and take a closer look. Turning quickly to the other 160 million Americans who have health insurance through other means. For the past 4 decades, states have taken the lead and regulated most health insurance. This role continues in virtually every state. Legislatures have enacted almost 2,000 mandates requiring different kind of coverage for specific treatments, such as autism or hospice care, diabetes supplies, or ovarian or prostate screening. And at least 40 states handle premium rate review. They've also initiated the idea of allowing adult dependents on family policies and have consumer rights and premium assistance of their own. So look for ongoing debates in this area. Now I will turn to Josh Ewing for a look at telehealth.
Thanks, Dick, and good morning, everyone. My name is Joshua Ewing, and I'm a policy specialist with NCSL's health program in Denver. Of the many issues I work on for NCSL, one of the most exciting right now is the issue of telehealth. It's been my experience that most first learn of telehealth in the context of addressing primary care workforce shortages and access issues in rural areas of your state. However, the reasons for growing telehealth extend far beyond rural primary care. Specialty consultations, behavioral health visits, and remote patient monitoring are all showing positive results in creating cost savings, business efficiencies, not to mention better patient outcomes. The best news, much of this may already be happening in your state. So what exactly is telehealth? I get this question a lot. Now, there are many different definitions of telehealth out there. In fact, that is one of the challenges facing state policymakers. But for today's purpose, let's just use the definition, the use of technology to deliver healthcare, health information, or health education at a distance. There are 4 generally accepted types or categories within the definition of telehealth. The first is real-time. And this is exactly what it sounds like, real-time communication. A great example of this is video conferencing with your doctor or a nurse practitioner, very similar to an in-person visit with your provider. The second most common type is store and for. Essentially, this is sending a file electronically. An example of this is most commonly used for radiology or dermatology, but it can also be used for consults with specialists. Next is remote patient monitoring. This is a fairly new and really cool area where your healthcare provider can receive information about your vitals or whether or not you've taken your medication without ever leaving your home. A great example is just what you see on the screen there with a senior. Instead of having to take a trip to their primary care office to just check up on vitals and very simple things, they can send it right to their doctor from the ease of their home. Finally, the newest category is mHealth or mobile health, and this refers to the rise of mobile health apps. This is a new and rapidly growing area that I think is going to have significant impact on the future of our healthcare delivery system. So quickly, here are the top 3 issues facing state legislatures regarding telehealth and telehealth adoption in 2015. The first is reimbursement. Very basically, state legislators are being asked to consider policies that mandate Medicaid or private insurance reimburse telehealth encounters at the same rate as in-person visits. Currently, 46 states reimburse for at least some telehealth encounters through their Medicaid program, and at least 24 states have laws for private insurance, although not are exactly parity. The second area is licensure. Right now, providers have to be licensed in the state where they provide care. Telehealth technology is now making it possible for providers to see patients across state lines and really across the country. As a result, state legislators are being asked to consider laws that would allow providers to practice across state lines. Some states are considering special telemedicine licenses, while others are going to be considering an interstate compact being promoted by the Federation of State Medical Boards right now that would allow for reciprocal licensure among the states that sign on to that compact. The final issue area where we expect state legislatures to take up this year has to do with patient safety and security. Within this, there are two main issues. The first being standards of care for telehealth encounters, or in other words, should providers using telehealth have to meet the same standard of care that a provider in in-person visit has to meet. And the second issue has to do with the security of patient health data. Simply put, we've all seen examples of hackers getting their hands on personal and financial information in the news lately. As we move to more and more toward an electronically based health system, what requirements should there be on health data? This has been a very brief overview, so please don't hesitate to contact me with any questions you have, or enter your questions in the chat box, and hopefully we can get to them later on in the webinar. Now I'm going to turn over the microphone to my colleagues Christine Goodwin and Tara Johnson to talk about public health.
Thanks, Josh. Since last fall, the challenges posed by infectious diseases have been really front and center issue. In the span of just several months, we've moved from the first case of the Ebola virus in the United States to a measles outbreak that has now affected 141 people from 17 states and Washington, D.C. At the same time, more people over age 65 years have been hospitalized for the flu than at any other time since the CDC began tracking data in 2005. These 3 examples underscore the challenges that states face and the important role that public health and state policies play. My name is Christine Goodwin, and I'm going to spend a few minutes taking a closer look at the measles outbreak and state immunization policies today. And then I'll turn it over to Tara Johnson, who will highlight other key public health issues. Since news broke about the spread of measles at Disneyland, attention is focused on state immunization policies and requirements for children entering school. While it's a hot topic right now, it's not really a new topic for states, which have had a long-standing role in setting vaccine policies, including passing laws that require children to have specific shots before they enter school. Every state requires students to be immunized before entering school, but they also carve out certain types of exemptions or exceptions to these rules. All states grant exceptions to children for medical reasons, and as this map shows, almost all states, those that are shown in orange, grant religious exemptions for people who have religious beliefs against immunization. 20 states also allow philosophical exemptions for parents who object because of a personal, moral, or other belief. Those states are shown in this map with the black netting pattern. The personal belief or philosophical exemption has become the matter of serious debate in recent years, and especially in recent weeks. In the last few years, lawmakers in several states, California, Washington, and Vermont, required parents to get a doctor's signature in order to claim a personal exemption, typically requiring that the doctor sign off that the physician had discussed the risks and benefits of vaccines with the family. Since January 1st, though, there have been a new wave of bills, at least 11 bills in 9 states that we've counted, but it's changing really by the day. And these would allow parents, they would either permit or restrict parents from claiming a personal belief exemption. A closer look at the bills shows that states are approaching the issue of immunization requirements in different ways. In the past month or so, a number of states have introduced bills that would set the process for claiming an exemption. For example, a number of states have introduced bills that would restrict a parent's ability to claim an exemption or to have to take some additional steps to claim an exemption. Another category of bills aims to really inform decision making and sort of provide some transparency for parents. Some states are responding by taking steps to share data to help parents make informed decisions. Some would require schools to make available their immunization rates, and others would require the health department or a state agency to disseminate that information. And finally, as with many policies, the devil is really in the details, and many of the active bills are taking steps to define and refine the process for claiming an exemption, looking at who qualifies for an exemption, at which schools, public, private, charter, daycare, and what steps need to be taken to obtain one. This rapidly changing hot topic is one that NCSL will continue to track, and we're here if you have questions. Now I'll turn it over to Tara, who will cover some other key public health challenges.
Thank you, Christine. Good morning. I'm Tara Johnson, and I will mention a few other timely public health issues. Public health remains a hot topic because it's working. When things are going wrong in public health, that's when people tend to notice it. There certainly are many prevention opportunities that states are currently investing in or have the opportunity to invest in to make substantial improvements in health outcomes. Often this is called low-hanging fruit. Timely prenatal care reduces smoking and other unhealthy behaviors that impact infant health and cost. States have taken steps to improve maternal and infant health by reducing early elective deliveries. The U.S. Department of Health and Human Services estimates that just 10% reduction in baby deliveries before 39 weeks of gestation would lead to more than $75 million in annual Medicaid savings for associated complications. States are promoting healthy kids and families by looking at policies to reduce obesity, promote breastfeeding, and increase early intervention and treatment for Medicaid-enrolled children. Lastly, chronic disease, especially cardiovascular disease and heart disease, are the #1 killer to Americans and create major healthcare expenses to the U.S. Every year, 7 out of 10 deaths are from cardiovascular disease. As you can see on this map on the screen, heart disease death rates can be more than double the rate in one geographic location versus another. Coronary heart disease alone costs the United States over $108 billion each year. Now I'll hand it over to Carmen Hansen.
Thanks, Tara. I'm Carmen Hansen, and my topic areas include the exciting areas of tobacco, including electronic cigarettes, public health winnable battles, prescription drugs, marijuana policies, substance abuse, mental health, cancer, and others. One of the hottest topics that I cover is the winnable battles in public health. These are priority areas from the Centers for Disease Control and Prevention's Winnable Battles initiative, which have achievable short-term successes, much like those low-hanging fruit that Tara previously mentioned. Tobacco cessation is still one of the preventable leading causes of death in the United States. State programs can often see a large return on investment on cessation programs for state payer systems, including Medicaid and state employee insurance plans. Healthcare-associated infections can be reduced by implementing policies and practices in hospitals or care facilities to reduce the transmission or contracting of preventable infections. Motor vehicle injuries can be prevented or reduced in a number of ways. One of the lowest cost but highest public reward outcome is the practice of wearing a seatbelt. Teen pregnancy and birth rates are at historic lows in the United States. However, teen birth rates are still far higher than most comparable countries. Teen childbearing has significant social and economic costs for teen parents, their children, and states. Fortunately, evidence-based prevention programs exist, and many states are undertaking comprehensive strategies to address teen pregnancy. Prescription drug overdose prevention is the unofficial 8th topic, largely because of recent epidemic status and potential to prevent and reduce adverse effects. NCSL offers technical assistance in these key areas, so please contact me for more information. Now back to Dick Kauke for some hot topics on prescription drugs.
Thank you, Carmen. Prescription drugs are 10% of overall health costs in the U.S., but often are higher on the list when health policy is considered by states and others. 50% of Americans take a prescription drug one or more times a year, and for a fair number of people, it can be a matter of life or death. States help lead the effort to contain costs with high visibility results. For example, the generally less expensive generics are now 85% of all prescriptions written. By 2013, overall pharmaceutical spending actually went down for the first time in 58 years. However, jump ahead to 2015, and a new set of issues are in the headlines. There's 3 recent buzzwords. First, specialty drugs, often called blockbusters by the media. These products can feature amazing new science and even new cures, but with high price tags. For example, new hepatitis C drugs went on the market at more than $80,000 for one course of treatment. Specialty prices in general are increasing 15 to 25% annually, leading to states and payers negotiating for lower prices and trying to manage use. Another expanding issue affects biologics, the complex organic-based medicines. This year, the first competing so-called biosimilar medicines may be approved by the FDA, in fact, within a couple of weeks. Since competing products may not be identical, this is leading to state legislation aiming to balance patient safety using notification and disclosure when a switch is made. Just last year, 8 states passed laws in this area, and at least 13 states have bills pending now. Another fast-moving issue is so-called right-to-try laws. What happens when a terminally ill patient wants to take an experimental drug not yet approved? 5 states just last year passed the first-time laws in this area. In 2015, we see bills filed in 25 states, and most of those are coming up for hearings in the next few weeks. Finally, another issue that has hit the states is halting compounding pharmacy errors. States, in fact, are the primary regulator of traditional pharmacies, while feds regulate manufacturers, and this left a gap. 2 years ago, contamination at one facility led to 64 deaths and more than 750 people falling ill. States rushed in to fix this, but it also led to a 2013 new federal law and regulations that now divides responsibility and adds a new type called outsourcing facilities. In 2015, you'll see a number of states rewriting their pharmacy safety and oversight. Finally, our health program is pleased to announce a new pharmaceutical bill database that will go live within a few weeks. Also, we have numerous reports on prescription drugs. With that, I'd like to turn to my colleague Ashley Noble, looking at cost containment and efficiencies.
Thanks, Dick. As Martha mentioned in the introduction, states spend an average of 30% of their budgets on health. This makes cost containment a perennial hot topic. In addition, legislators hear from their constituents about health costs. The average family's premium now costs almost $17,000. Costs have an effect on every part of health care. For example, treating chronic diseases costs for about 86% of all health care spending. Many chronic diseases and conditions are preventable. So, for example, by decreasing levels of obesity, improving diet, and exercising more, we could prevent thousands of deaths related to heart disease, stroke, and type 2 diabetes, while also saving millions of dollars spent on treating these conditions. States can help to control the cost of healthcare while also improving quality of care. NCSL has a number of resources available to legislators and staff on dozens of topics related to cost containment. An important trend in recent years has been the increasing importance of cost transparency and disclosure. Transparency and disclosure requirements are used in a number of ways to enable consumers to better understand and make choices about their care. For example, Rhode Island requires that a hospital inform patients if the hospital does not participate in a hospital service plan. South Dakota requires hospitals to disclose all fees and charges to patients upon request. Other states require that patients be given itemized bills under certain circumstances. Related to this topic is also the rise of the All-Payer Claims database. These databases allow practitioners and consumers to see what different medical treatments are being offered by different providers, as well as the cost of those treatments. We have an entire web page devoted to transparency laws, as well as other materials compiled in memo form. Although premiums are rising at a slower rate than in years past, they do continue to rise. One strategy that states use to address rising health insurance premiums is a practice known as rate review. States that use rate review require insurance carriers to submit their proposed rates to a state agency. At least 35 states have the authority to approve or deny premium rate increases. Like premiums, costs borne by the consumer are prominent in the minds of legislators and their constituents and are likely to remain so in the future. Typically, consumers are responsible for a greater portion of the costs associated with treatment from out-of-network providers. New Jersey and New York introduced legislation in the 2013 and 14 legislative sessions that would have required patients to be informed when out-of-network providers may be used in their care. We're also developing a new database on health systems reform that will cover, among many other topics, costs. And with that, I will now pass things back to Carmen.
Thanks, Ashley. NCSL's coverage of substance abuse and mental health includes what legislators are most often asked about. Ideas to prevent prescription drug abuse is one of the most commonly asked questions, followed by connecting people to mental health and substance abuse treatment and related insurance coverages, and the duties and responsibilities of mental health providers. There are also ways to integrate behavioral health issues with primary care in order to expand access. One of the other hottest state policy topics in recent years is marijuana policy. Since 1996, 23 states and 2 territories have legalized the medical use of marijuana or cannabis products. 11 states allow for low THC or high CBD cannabis products for medical use, and 4 states and DC have passed legislation to legalize adult use of cannabis. These programs are highly regulated in a variety of ways, which we cover online on our marijuana policy page. Once an issue largely addressed through the ballot initiative process, more state legislatures are introducing legislation to legalize various forms of cannabis products for medical and adult use. States with existing programs are proposing various changes to their existing programs, and usually it's to improve regulation and reduce the potential of diversion. My last topic is electronic cigarettes, alternative nicotine devices, and vaping in general. At least 41 states ban the sale to minors. 2 states have special taxes for these devices or liquid nicotine, and states define electronic cigarettes differently, and they are very complicated products in general, so it's important to understand what they are or what they aren't before considering policy to regulate them. The current issues with these products are how to tax them and if they should be added to clean indoor air laws. Federal regulations may be announced as early as April 2015, but most likely to be released over the summer. And now I'd like to turn it back to Martha for a wrap-up.
Thank you, Carmen, and everyone. So these are just a few of the hot topics in health that we are following and that you may have experienced in your own state. We're sure that you're dealing with dozens of other health issues, and we hope that NCSL can be a good resource for your information needs. To that end, we'd like to remind you that NCSL has numerous resources available to you. After all, NCSL is your organization. We have hundreds of web pages. We produce publications that you're familiar with, including Legisbriefs, our magazine, different reports, and our popular postcards. In our health program, we answer over 1,000 information requests each year, mostly from our own legislators and legislative staff. We also service the media and other state government agencies and our foundation sponsors. We put on meetings and seminars, And we provide technical assistance to states that request it. For example, we can sponsor testimony before a committee, and of course, we don't take a position on any legislation. We'd like to open the webinar up for questions, so you may type your questions into the Q&A box on the left-hand side of the screen. Earlier, you might have seen a dialogue going back and forth there, but we have fixed it so that if you do type in a question, you will not be identified, nor should your question show up. Thank you very much for participating today, and we do have a few questions that have come in. If you do ask a question and we can't get to it, we'll be happy to follow up after the webinar. Let me start. Melissa, here's one for you. For states that have had federal grants under the STEM or the State Innovation Model federal grants, are there any results yet that other states can learn from?
When thinking about the evaluation of SIMS and the outcomes of SIMS in terms of actually moving the dial in cost and quality of care, it's too new, and a lot of the SIMS grants were actually for planning purposes. We're just now starting to see implementation and see some of that data come out. So it's too soon to speak concretely about evaluations, but I do think it's worth noting that SIMS is being used in some states as just sort of another tool on reforms that they've been working on for years. A lot of SIMS states are using techniques that have been used before and just expanding them. So I think we are getting really good data about what it means to do multi-payer, what it needs to get stakeholders together. So while the in-game data is not available, there's definitely some interesting lessons learned or best practices about stakeholder engagement, as well as some challenges and barriers to getting multi-payers together, specifically working with Medicare.
Great, thank you. And Carmen, when are final federal regulations of e-cigarettes going to be announced?
That is an excellent question. The FDA Center for Tobacco Products did announce a couple months ago, when they closed the comment period for the proposed regs, that the final regulations would be announced no earlier than April 2015. That said, these things are notoriously late, so I am hopeful that they will be out by sometime this summer. And these regulations would generally treat e-cigarettes like traditional tobacco products and how they are sold and advertised. And there could be other things that are tossed in there that weren't necessarily in the proposed regulations, but generally speaking, they would be treated similar to traditional tobacco products.
Great, thank you, Carmen. And here's one for you, Christine. You talked about exemptions from vaccines for kids. Are you seeing trends in the non-medical exemption bill?
Yeah, thanks, Martha. That's actually a question I've been hearing quite often, and it's sort of hard to answer because it's a mixed bag. I mean, since January, a number of states have introduced bills that don't really fall in one camp. Some of them would even expand the process for claiming an exemption, but I think the numbers are really more of these would add additional steps or make it effectively more difficult, I guess, for parents to claim an exemption. So, you know, they might require parents to talk to their physician and have a signature. They might require a process for submitting the forms annually versus once and not again. So sort of fine-tuning the process, I guess, for claiming an exemption. And then I think, as I talked about, I'm seeing more bills that really, I guess, present opportunities for parents and the public to know immunization rates in their schools and to really, I guess, benefit from information about immunization requirements and then status at a school level.
Great, thank you, Christine. Ashley, here's one for you. How many states have enacted price transparency and disclosure laws?
That's actually a really great question. So at least 28 states have enacted legislation on this topic. We have those laws listed on our price transparency page.
Great, thank you. And Josh, I think there's some confusion between talking about telehealth and telemedicine. I know that confuses me a little bit. Can you help enlighten us?
Yeah, that's a great question. That's something I should have hit in my slides. A lot of times the terms telemedicine and telehealth are often used interchangeably, but I think simply put, telemedicine refers to that direct medical encounter that you would have with your provider, where telehealth is a little more comprehensive or a broader term that includes things like all of those categories that I referred to, so remote patient monitoring, the sending of images, now mobile health apps. So it's a little more inclusive, and I think it speaks to a broader issue that I think we're facing with a rapidly evolving tool like telehealth. And so I'd caution legislators and legislative staff on this listening to this webinar. With something that is so rapidly evolving like telehealth, we need to be cautious about the terms we use so that we don't stifle the innovation that's occurring in the medical field right now with a tool like that. Definitions mean a lot, and I think it's a struggle that state legislators are seeing right now as they try to help grow this technology in a safe and effective way.
Great, thanks, Josh. And Dick, you talked about the quote Dallas Buyers Club bills, unquote, the right to try bills. Have some states passed legislation?
Yes, in fact, in 2014, 5 states almost competed with each other to be first in line: Arizona, Colorado, Louisiana, Michigan, and Missouri. And then this year, as I say, there are 25 states that have bills, from Arkansas to Wyoming. NCSL does have a report updated just in the last 7 days online that lists out both the enacted and the pending and the outcomes.
Great. And Carmen, you talked about the hot topic of marijuana. Living here in Colorado, we know that Colorado and Washington State have legalized. And are there other, and DC, are there other states that are looking at, quote, legalizing, unquote, marijuana within their state?
Sure, thanks, Martha. Oregon and Alaska have been the most recent to pass those types of programs for adult use in the 2014 elections. And so far in the 2015 sessions, 12 states have filed bills to create medical marijuana programs. And rumor has it that another handful or so may be introduced by the end of the year. And as far as the kind of regulating marijuana like alcohol type legalization for adults, 8 states and DC have introduced bills to legalize marijuana for adult use. And there could be another 10 in addition to these by the end of the year if all of the folks that have been saying that they're trying to introduce something actually get it that far. And the DC bill through the DC Council needs to be reviewed by Congress, and the discussion has been that Congress is not likely to approve that, so the DC law to allow for adult use is kind of held in limbo currently.
Great, thanks. And a couple of you mentioned chronic diseases. We have a question about, Ashley had mentioned that a huge proportion of health costs go toward treating chronic diseases. And Tara, you talked about chronic diseases in your public health presentation. Tara, could you tell us a little more about the chronic disease points you were making?
Sure, Martha. Yeah, as Ashley had mentioned as well, chronic disease is really a big issue in terms of health outcomes, but also health costs. And about 600,000 people die every year from heart disease, which is almost 1 in 4 deaths. So quite a few people every year, and that does range in age. Every year, about 720,000 Americans have a heart attack. And of these, over 500,000 it's their first heart attack, and over 200,000 happen in people who've already had a heart attack. So when we talk about prevention, it's really important to think about the prevention for a first incidence, but also a second incidence. So that ties in medication adherence, that ties in a lot of the preventative activities that we talked about, physical activity, proper nutrition, etc. We have quite a lot of information about chronic disease in general, but also specific diseases on our website, and I'm happy to answer any other specific questions that folks may have.
Great, thanks, Tara. And here's one on the all-payer claims databases. How many states have adopted those, Ashley?
Sure. So according to the APCD Council, which is a organization that lives and breathes this topic. 11 states have existing all-payer claims database, and another 6 states are currently in the implementation phase.
Great, and back to you, Tara. You mentioned that states have taken measures to reduce premature birth. Just what kinds of things are states doing about that?
Yeah, absolutely. States have taken a couple of different measures to reduce early elective induction and cesarean deliveries, such as restricting reimbursement for them, educating patients and providers, monitoring performance and reporting, and also coordinating efforts to disseminate best practices to prenatal providers. At least 4 states, Illinois, New York, Texas, and Washington, have passed laws to reduce early elective deliveries. Texas, for example, will not reimburse for an early delivery through Medicaid unless it is medically necessary. Other states have taken various routes in doing the same, as it reduces costs for Medicaid, but it also improves birth outcomes, which we all know saves costs in the long run. Other policy opportunities also include improving prenatal care and getting women into care earlier, and that helps improve birth outcomes. Also improves outcomes for the mother as well.
Okay, great. Thanks, Tara. Okay, we have one about biosimilars. Do you have any comments you can make about biosimilars? Would be appreciated. You can be extemporaneous, Dick, here.
I'm sorry, Martha. Say that again.
Would you talk a little bit more about what are you talking about biosimilars and what are the state policy issues for states?
Well, the issues essentially are that there are quite a few biologic medicines already on the market, and the concern has been growing that there are already in the works what are called biosimilars. That is, medicines designed to do exactly the same things as the original ones on the market. It's not really the same as the traditional brand name and generic product, where the generic companies simply were using identical formulas to produce less expensive or more available products. In this case, because of their manufacture as from living organisms, they are not truly identical. And so the FDA has been given the task of determining at what point a second drug can be declared to be a so-called biosimilar, and then separately whether it is truly interchangeable. Once the FDA rules that something is interchangeable, it goes to the states, which traditionally regulate how these relationships work. And so states have been looking at laws, and 8 states so far have passed laws that would establish basically notification and disclosure requirements. They don't prohibit a switch. They require that the original prescriber, presumably the physician, would be notified if the pharmacy determines that something is available and makes a substitution. And in some cases, the patient would also be notified. And then records would be kept so that if there was some adverse effect or just result of interest, that the pharmacy would be required to have a record of that for perhaps 2 years or 4 years. And that's where the state language varies to some extent.
Great, thanks, Dick. And here's another one. Melissa, what type of alternatives have you seen states to the Medicaid expansion?
So a number of states have submitted 1115 waivers to expand Medicaid in sort of unique ways. And there are differences in all of these waivers. So I encourage folks that are interested to either contact me or go to the Centers for Medicare and Medicaid Services website to look at the language of these waivers. But in general, there's a lot of emphasis on engaging beneficiaries in new ways, as I mentioned, a focus on how can we create personal responsibility, engage them in some wellness activities, tie that wellness activities to maybe some costs or some co-pays, as well as using, leveraging the private market that's allowing beneficiaries to use Medicaid dollars to buy a product available through the exchange, so in the marketplace. So those are the trends that the biggest set of trends that I'm seeing. But each waiver is different, and I encourage legislators that are interested to either look at the waivers or the summaries, or to please feel free to contact me to ask any specific questions.
Great, thanks, Melissa. We do have a few questions about the slides being available on archives. You can download them now as a PDF. If you go up at the top bar, the little icon that shows a yellow piece of paper with a blue graph in front, you can click on that and download them. We will also post them to NCSL's webpage. How many states have tried to introduce hospital cost transparency legislation? Did you cover that?
I would have to look up that answer, but I can get back to them on that.
Okay, Carmen, what trends are you seeing in terms of taxation of e-cigarettes?
That's a great question. Right now, the industry has been proposing some model legislation in this area, which tends to be what I'm seeing introduced. It is for 5 cents per milliliter of electronic e-juice or liquid nicotine. That's a little harder to calculate when it's a closed system, when it's like one of the single-use e-cigarettes or one that lasts a while. It's not the tank model where you actually fill the little cartridge with the liquid. Those would have to be labeled as how much liquid they include and then be taxed accordingly. So it's a little unclear yet if how those could be taxed, but if they're labeled with the content of liquid nicotine, then it's a little more easy to calculate and straightforward. But for right now, the bills I've seen are largely the industry model of 5 cents per milliliter.
Great, thanks, Carmen. And we have a question, Dick, on the prescription drug database you talked about that's going to be unveiled soon. What will the user be able to use within or search for in the database?
Well, it will be live and sort of 24 hours, 7 days available and free to the public, although it's always good if you sign in as a member, but it's not actually required. The database will include several fairly broad categories, not every single bill affecting pharmacy technicians, but we will be looking at broad issues like coverage and cost, particular look at specialty drugs, compounding pharmacy issues, and you'll be able to select by those topics or enter an actual keyword, or also look at states. You could look at the 5 states surrounding your own to see what else is out there. It also allows you to actually do full text search on that particular word. So it's pretty flexible, and it should be a tool. We're excited because we've never had the resources until now to have a prescription drug database. It also updates every week, so once you know what your topic is or your bills are, you can go back and see how they're moving along.
This is Melissa. I'd like to add on that in addition to the prescription drug database, we also have an injury prevention database, and within that database, prescription drug abuse is tracked. So any legislation that looks to prevent the abuse of prescription drugs will be available. The database is very similar to the data, as Dick outlined, as all NCSL databases are. You can look at all states and do keyword searches, and that will be available in the next couple of weeks as well.
And here's another one for you, Melissa. Have any states implemented behavioral health homes as a cost-saving measure in their state Medicaid programs, and have they reported any results?
You know, that was something I don't have the data in front of me. I would have to look that up or refer to Carmen if she has any knowledge on the behavioral health home side.
And then I think we have time for just one more. Is NCSL tracking any efforts in federally facilitated marketplace states to respond should the Supreme Court rule in favor of King versus Burwell?
Yes, as part of our health system tracking, we are looking at that. It's still early in the year because many states can file bills along the way, but so far we've observed bills in Indiana, Maine, Missouri, New Hampshire, New Jersey, Pennsylvania, Ohio, Texas, and Virginia. That's not necessarily an exclusive list. And of course, in our bipartisan way and nonpartisan way, we're also looking at bills that would block or eliminate existing, perhaps state-run exchanges. So both sides will be of interest this year.
Great. We do have a handful of other questions in the queue. We will get back to you by email if we didn't get to your question. We want to thank you very much for participating today and thank our NCSL staff for this team effort too. Again, thank you and have a great weekend.